Welcome to Medication Talk, the official podcast of TRC Healthcare, home of Pharmacist Letter, Prescriber Insights, RX Advance, and the most trusted clinical resources. On today's episode, listen in as we discuss strategies for reducing risks with opioid use, including safe opioid dosing and identifying risky med combos. You'll also hear a review of the different opioid overdose reversal options and important counseling tips for all patients taking an opioid. Our guest today is Dr. Jeffrey Bratberg from the University of Rhode Island College of Pharmacy. This podcast is an excerpt from one of TRC's monthly live CE webinars. Each month, experts and frontline providers discuss and debate evidence-based practice recommendations. The full webinar originally aired on April 16, 2024.
And now, the CE information.
This podcast offers continuing education credit for pharmacists, physicians, and nurses. Please log into your Pharmacist Letter or Prescriber Insights account and look for the title of this podcast in the list of available CE courses. None of the speakers have anything to disclose. Now, let's join TRC editor Dr. Sarah Clockers and start our discussion.
We all know that managing pain with opioids is one of the most challenging areas of clinical practice. The potential benefits of opioids in achieving improvement in functioning and adequate pain relief must be weighed against the many risks. We really want to just think twice before writing for an opioid or slowing down when filling an opioid prescription. The other thing I think we all want to do is just considering all the options to manage pain before we start an opioid. We really want to emphasize the importance of the non-drug measures like exercise, physical therapy, acupuncture, rest, and ice, and then the non-opioid meds for most patients, such as an NSAID for kidney stone pain or duloxetine for neuropathy. But we all know we need individualized care, and there may be some circumstances where a patient needs an acute opioid prescription, such as major surgery or a sickle cell crisis, or patients may need to be on long-term opioids to function daily when other measures aren't effective or an option. So, patients with kidney disease who can't take NSAIDs, or in some of our patients with cancer. So today we want to focus on those patients that may need an opioid and see how we all play an important role in optimizing the safe use of opioids. We're going to focus in on safe dosing strategies, avoiding risky combos, and then overdose reversal agents. So, Jeff, to kick us off, can you briefly review some considerations when thinking of starting a patient on an opioid?
So I always think about opioids as, thinking about there's two ways to use them, right? So there's acute conditions where opioids may be necessary and used in as low a dose, lowest effective dose, and as short as possible, short duration as possible. But then there are people who have chronic pain syndromes, and we have to think about what have they tried before. Sarah talked about non-drug therapies. We talked about non-opioid therapies. Have we maximized those? What are limiting the patients in those ways? And we layer on opioids on top of that. But again, we treat folks who are using opioids chronically somewhat differently than people who are using them acutely or, less than 7 days, for example. So of course, we also have to think about comorbidities, organ function. But I think what my goal of this talk is to say, if a patient is in pain, we believe them. And just like we start a medication for any person, we have the same kinds of checklists, honestly, is that we say, is this safe and effective for them? And opioids are safe and effective therapy, and we just evaluate similar things. So what is their substance use history? Have you developed a rapport with the patient? I love the idea of every interaction with the patient is patient-centered care. What do they want? Because whether they have success or whether they have trouble staying adherent to the opioid for one reason or another, taking too much, taking too little, having pain, breakthrough pain, we need to hear those things. And patients are, opophobic too, just to an extent, where they hear all these things about opioids, they're unwilling to do it. So you need to have the confidence as a prescriber or dispenser or anyone who interacts with the patient and their family, plays a big part, to say, how do we get you through this acute setting? Or if we're going down a journey where you're going to take opioids chronically, what are the best ways to keep you safe? What are the most effective doses for your particular conditions and situation? And how can we monitor you in a compassionate way?
That is an excellent overview. And I think, too, the other risk there is untreated pain and where that can go for patients who don't have great pain control in chronic pain conditions. So making sure that there's the right balance. It comes back to individualizing that care. Let's go ahead and jump to safe dosing strategies. When we're thinking about starting an opioid, what is the first thing that comes to mind to do it safely? How should you recommend starting an opioid?
I think if we put pain control as a function of how we treat other chronic diseases or newly diagnosed diseases, to say, okay, what is your expectation? Our goal is not the elimination of pain, right? It is a mitigation. It is quality of life. It is how do we balance the potential limitations or side effects of opioids with the benefits in terms of, again, whether it's somebody playing with their grandchildren or playing with their children or functioning at work, if they have improved sleep. Those are the things that we need to talk about. Is this something that is going to be long term, and having those close conversations and frequent conversations about that? Or is it, okay, you have this pain and the severity and these other strategies aren't working. You try an opioid, see how it works, and then work with the patient to say, okay, now when do you want to go off this? Very few people actually of people who take opioids, take it for a very long time or beyond 90 days as the CDC classifies chronic pain. So we have to think about sort of, there's the 7-day period, there's the 7 to 90-day period, and then we have different conversations when we go beyond the 90 days. But even after those 7 days, or some say as short as 3 days, you can have withdrawal. And that is a amazingly difficult thing to go through. Again, in those patient arrangements, we want to say, hey, if you stop your opioid, tell your doctor about it. Like as a pharmacist, what do we counsel our patients on? Talk to your doctor or pharmacist if you change how you're taking this drug. So that rapport is essential, making sure the patient knows the effects of that opioid and why they're taking it and what to expect. And don't stop abruptly, because withdrawal is going to, especially if they're unaware that that could possibly happen, you're going to damage the relationship, which is really so important to, again, managing pain along with other chronic diseases.
Yes, and I think we say in a lot of our articles to have an exit strategy. So setting those expectations with the patients ahead of time is super helpful. Letting them know this isn't a long-term thing. The pain with this surgery usually lasts about a week. Setting those expectations.
Well, and again, I think what I hear anecdotally in folks in practice is that there are people who are given an opioid after a surgery, and because they've heard so many horrifying things about opioids, they don't take it and they unnecessarily suffer. So I think of it as more of a community or public health effort to say, you can take opioids, you can do it safely, you can improve your quality of life, and you can stop them in these short periods of time for these moderate to severe pain syndromes like certain surgeries and things like that, where yes, you can take the opioid.
Yeah, that's a good point. What are some of the different types of discussions that you have with patients when you are trying to decide whether long-term use is right for them?
Well, I think it's the same conversation about stepping up therapy, maximizing those non-pharmacologic therapies. What kind of pain is it? Often people will start to have different kinds of pain.
Mm-hmm.
And so you mentioned duloxetine, is there a neuropathic component? Are we managing the conditions that are leading to the chronic pain? I think the most important thing is behavioral health, right? So some folks
Mm-hmm.
include any kind of substance use disorder, both opioid or other substances, whether legally available or not, but also mental health, right? Depression and pain go hand in hand. And so sometimes opioids, they work on the same receptors in the brain. They can have effects on depression. Some people say it relieves their depression. Some people it deepens it. So I think it's important that when folks have pain, and I think it's really hard for us to imagine what it's like to have pain that limits our function for more than 3 months, you really need to have those behavioral health conversations and maybe add adjunctive agents and obtain a diagnosis for depression or anxiety or those kinds of things.
Yes, treating those comorbidities is
Right.
super important. Yep. So let's move along. And you mentioned earlier, tapering off opioids even after just a few days. So how how do you decide this patient's going to need to taper off versus I can just tell them to stop? Is there like a general guideline that you use?
Well, again, so it all depends on the regimen, what their experience is, how naive they are to opioids, how their pain is. Very often people will say, I got prescribed this 7 days or these 3 days, and I only took one. Well, you don't need to taper off of one, or you took 1 day or 2 days. And then there are people who maybe they're prescribed something and they're taking their as needed as well as a chronic med. They say, well, I took these pills 4 times a day and I was told to take it for 2 days and stop. There might be some withdrawal. So making sure that folks know what withdrawal looks like and knowing that it's okay to go from 4 times a day to 3 times a day to 2 times a day to 1 time a day. That makes sense. But if they have pain, it's okay to take more. And my favorite strategy is if it's a 7-day therapy, give them the expectation to take it 3 days and check in. How are you doing? What is your function? Do you need to take more? Or if you have signs of withdrawal, reach out and let's design a strategy and let's give you instructions on how to do that. Yeah, so withdrawal symptoms is that anxiety. I mean, I know somebody very close to me who had a broken collarbone, took opioids for 4 days, had sweating, anxiety, didn't know what was going on. We were all told you don't have withdrawal if you take 7 days. And every patient's different. And it's really all about, when we think of tapering, explain to the patient that it's about slowly going off the opioid to avoid these symptoms. And I think if you, again, are clear with the patient about what withdrawal is, how to avoid it, and why we're continuing to take pills, I think everyone will have a good outcome.
That's great. And then what about a general rule for patients who are on chronic opioids for years and you're trying to, slowly wean them down? Is there a recommended amount to reduce the dose by? I know in some of our articles we say about 5 to 10% per month. Just take it really slow because the goal is to get patients off of it. Is there anything like that you would recommend in your practice?
Yeah, that's what I would say. I would say in your example, if it's years of opioid use, I think the most important thing is really it is not our job as clinicians, even in great relationships with patients, to say now it's time to taper. For those people who are on for years, they've lived in fears and still do in some places of actually just maintaining their opioids. The best studies that I cite are those where patients, if they self-initiate the taper, they are much more successful in their goals, which could be just a lower dose every day, or it could be completely going off. And so I think very, very importantly, there are clinicians who, in the guise of doing right by their patient, actually don't do them right and do these aggressive tapers where it's 10% per week or it's 50% per week to say, okay, now it's time to go off. Those are really dangerous situations to avoid. I think we're all not going to do that. I think, again, 5 or 10% per month, close monitoring, see how the patient is. And we need to have the expectation that, yeah, maybe it's 50% in 6 months, and that's where they're at. And that's the function they want to be at.
Yeah, patient buy-in is huge. And I think something else to consider too is giving the patient options. We could do it this way or we could do it this way. And once they can make that decision for themselves, and that seems to help things move along as well.
As we talked earlier in long-term chronic pain patients, is that you still need to evaluate everything else that's going on. Did this person have chronic hip pain and then had a surgery and now they don't? And now that's the time. Is it because they just want to? I think that's great, but look at else what's going on. Is it they're no longer depressed, or they've tapered off their behavioral health medications, or they're now receiving counseling and they can have more function? Really evaluating what else is going on still with other agents, so that the tapering of the opioid doesn't trigger, I shouldn't say trigger, but so there isn't some sort of pain crisis and then it's back on the opioids and now their goal is not what they want and causes more problems that way.
That was a great discussion, and I'm going to move us along so we can talk about switching opioids. We actually have a question coming in about shortages. That is one indication for switching opioids. And then we often will do it for insurance reasons or changes in kidney or liver function. So is there a general kind of guide that you use when you're helping patients switch their opioids?
If there's shortages, there's the rare patient who's functioning really well on a branded medication, it becomes generic, and it's sort of, what is the insurance requiring there? Really using those echo-analgesic dosing charts to say, are we switching to something that's extended release from immediate release, or vice versa, because we're tapering and we want to have more sort of control of that, comorbidities like kidney or liver disease, if it's improving or not. But it's really going, okay, where are they at? Use those charts. What is their goal? Why are we stopping? Sometimes there's a switch and they want to switch back. So again, I think this is always an opportunity to think about reviewing patient goals and saying, okay, is this time to start at a lower dose, which is potentially safer, but shouldn't always be the goal. I think we want to look at what they're taking in a total dose, where are they at, and then thinking about how we overlap those opioids so that we don't have any period of time where there's unnecessary pain.
So this is one area that these patients are at an increased risk of overdose. There is that incomplete cross tolerance between opioids that we want to make sure everyone's aware of. So having that discussion with patients too. In a lot of our articles, we do say it's more art than science. So we definitely want to go through and just be more cautious. You can always increase the dose.
Right. I think it's what's usually said is, depending on the severity of pain, either initially or, again, how well they desire their control to be. For example, we say, let's reduce the total daily dose as we switch to 25%. Some people say as much as 50%. I would stay around 25%, depending on how the math works out. But you're right, we can always add, if they're on a stable long-acting dose and they want to switch to another long-acting, you can always have breakthrough pain medications, and we can adjust up from there. I like that process.
Excellent. And just a quick plug for this chart, our echo-analgesic dosing of opioids for pain management resource. It does have a great dosing table and also resources for those less straightforward meds, so buprenorphine, fentanyl, and tramadol, some of those that aren't as easy to switch between. I think it's super helpful.
I teach at a pharmacy school, and this was literally an activity we did yesterday, unbeknownst to me. So it was great to tell the students about these charts and realize that these are there to help them both in school and in practice.
That's awesome. So let's transition on to how we can work to reduce risk by avoiding risky combos with opioids. So, Jeff, just off the cuff, what are some drug interactions that are most concerning with opioids that you're going to like, oh, this raises a red flag, I don't want to dispense these two meds together? Is there like a certain list of drugs in your head that you're like, not doing it as being most concerning?
Yeah, thank you. So I think, benzodiazepines are most often used. And I think where I see the most concerning combinations are the use of benzos with opioids, but especially in older folks. And so, again, what's the worst case scenario of opioids? It's opioid-induced respiratory depression. It's overdose. It's using too much, what we like to call a breathing emergency. And so I guess if I was to choose a population where I'm most concerned about, is that there's increasing amounts of co-prescribed benzos and opioids. Some data that we see more people dying with both substances in their system. And these are both prescribed medications. They both are reported in states' prescription drug monitoring programs. So really find out what's going there. Again, we can have a whole hour discussion about tapering benzos, which often takes years. It's probably more difficult, in my opinion, than opioids. So really figuring out, why is this person on a benzo? Why is this person over 65 on a drug that's on a Beers criteria list? And then, of course, we do see increased alcohol use, actually in the same population. So as we see our population age more and we see more alcohol use, we see more benzos prescribed despite guidelines recommending not to. Again, they are more difficult to come off. And we do have other drugs that are used to treat anxiety or depression that have been implicated as concerning with opioids, like SSRIs, but absolutely more safer than benzos and probably more effective to treat those behavioral health issues.
That's great. We do have those pharmacodynamic considerations. In addition to the CNS depressants, we also have serotonin syndrome. It's extremely rare to see this, but it can be pretty scary. And so there are some opioids with serotonergic properties. And I think you were kind of alluding to some
Mhm.
serotonergic meds just now. So what are some of those opioids that we would want to just slow down and make sure that we're not just overlooking something that could be potentially harmful?
Well, I think, again, we have such a wide selection of opioids that don't have these things. Again, I think fentanyl I would be less concerned about than tramadol and riperidine. And fentanyl comes in so many different forms, and we can monitor it. Again, this is pharmaceutical fentanyl, which is extraordinarily effective and extraordinarily good for chronic pain or pain of oncology or cancer patients. Tramadol is just, if all tramadol went away, here's my hot take, I don't think anyone would suffer both for this and just it is just a weak opioid with all kinds of side effects. And I see it prescribed, and I've had family members prescribed it, and it's used. And I just don't see really any niche for its use, again, for this reason or other reasons. And again, I think it's important. So, methadone for pain, again, we have, I think, better medications that are safer and easier to monitor. Methadone for opioid use disorder, yeah, often goes together with pain syndromes. And so I think in that setting, methadone is the better choice. But yeah, SSRIs, SNRIs, realize these are medications that are co-prescribed for neuropathic pain. TCAs probably should avoid, again, depending on what kinds of comorbidities this person has. And I'm always thinking about older populations. It's really doing a risk benefit, and it's great. It's having pharmacists and prescribers all working together with the patient and their family to find the best outcome for all their disease states and all their medications.
Great overview. And I think too, some of these serotonergic meds are also involved with some of the cytochrome P450 interactions. So what we start to see and worry about is stacking of meds, right? So if you have patients that are on multiple drugs that are inhibitors of 2D6, and then there's on a serotonergic opioid, we just start stacking all of these things, and then we're not sure which ones are causing what problems. So I think it's also just important to note that some of these opioids do also get metabolized via CYP2D6 and 3A4. So those are also good to just kind of point out and know what some of those common offenders are.
I'd say this is just all part of the safest medication is the one that they don't need and can be stopped or deprescribed.
Mm-hmm.
I think there's also, we have to look at sort of the holistic view of the patient to say, what diseases are we treating? These are, in some cases, relative contraindications, and we can, again, monitor people's pain. For some of the anticonvulsants, we can monitor through serum levels. Think about how closely can we monitor these things? What exactly are they there for?
Yes, and then we add in all those other specific patient considerations like kidney function and liver disease and aging and respiratory concerns. So some of those underlying conditions that can also impact, and it just makes it very tricky. So I think that's a good discussion, and when you're trying to figure out if a patient's a candidate, something to evaluate. All of these things fit into that bigger picture. So on that topic, we did have somebody chat in a question about, is it safe to use opioids in patients with kidney disease? What's your response to that? And are there certain opioids that are safer in patients with kidney disease?
Yeah, sure. It's a very, very common question. And again, my pharmacist brain's always thinking, what is the degree of kidney disease? Is it progressive? What's happening? Is this stable or not? And so we always have to characterize that. And just because someone has kidney disease, we have lots of guides to adjust medications for decreased, clearance of creatinine or decreased kidney function. So rarely will we see that things are contraindicated until we get to higher stages of disease. And there are some medications that are not cleared by the kidney or are safer to do that. And I believe fentanyl is one of those. And so then you can kind of consider to say, well, let's take the kidney disease out of the equation and choose a safe and effective opioid that isn't going to be modified by that, just to focus on other factors that in terms of how we choose and maintain people on opioids.
Yes, and some of those do accumulate, the codeines, the meperidines, we would want to avoid those in patients with kidney disease as well. So that's great.
And I would just avoid codeine and meperidine all the time. It's just a really easy thing. Just avoid tramadol and codeine and meperidine all the time. Scratch them off your list, and that'll be great.
Yep. And that applies to liver disease as well. So I would put codeine and meperidine and tramadol on my do not use with liver disease list. What's on yours?
That you said the same things.
Okay. Good. Okay. Well, let's go ahead and transition on to opioid overdose reversal agents. We have many factors that increase the risk of opioid overdoses, and many of the things we just talked about. Patients with a history of overdose or substance use disorder, high doses, when we're switching, they're at increased risk. And then all these different medication combos, patients who have respiratory problems or liver and kidney disease. So we really want to make sure that we keep an eye on patients that fall into this category. But I think the other thing that we say in several of our articles is anyone that uses an opioid may be at risk for overdose. So we don't necessarily need to focus on certain people. We can just consider, if somebody's getting an opioid prescription, they're at risk. So Jeff, can you give us a brief overview of the available opioid overdose reversal agents?
Absolutely. So everybody listening here and everyone you know is a first responder to opioid overdose, regardless of what opioid caused it. And so that means that everyone, probably everywhere you live, has access to naloxone in several different ways now. So naloxone, which goes by different brand names, the most common way to access it is the intranasal version, a 4 milligram version, and that is over the counter. And so you can, right now, in our research, only available in pharmacies, and so you can find it over the counter. There are still products that are on standing orders in states, and so you can always ask your pharmacist to fill it through a standing order. You can ask your doctor to fill it that way, or there's, in every state, there's community programs that distribute naloxone for reduced costs or free, available in vending machines. There's those types of things. There is a higher dose of naloxone, an 8 milligram spray, not as effective, may lead to more withdrawal without any greater effect. So we probably don't need any higher doses. There are injectable forms, again, depending on where you are, how comfortable the patient is. You can titrate those doses. The intranasal forms you can't. And there's a newer marketed agent called nalmefene, which again comes in injectable and a new intranasal spray. The features of nalmefene are that it lasts longer. It doesn't last like naloxone. But again, the longer that it lasts, there's no data that shows that it's any better than naloxone. The concern is that it may extend withdrawal. And as we talked earlier, anyone who takes an opioid and has withdrawal and then it's extended may be less likely to actually seek care, again, in the setting of opioid overdose and opioid use disorder.
That is a great overview. And I think we often just emphasize to increase access to any of these agents rather than focusing on which product to use.
The only thing I was going to build off of that is that it's great to know that it's available. It's great to know that you have it. But every time that you're around another person, it's important to have naloxone on you, right? In your bag, in your car. There's many, many people who have naloxone that is sitting in a kitchen drawer. It is not available for you to help reverse overdose and save a life. So it's always important to really have it on you. And that is also part of the way to reduce the stigma of opioid overdose or these reversal agents themselves.
And that's what I was just going to ask you to comment on, as many people do struggle with how to bring these up to patients. So what are some tips in just kind of working it into the conversation, just like you would work in, this is a side effect, you'll have constipation with opioids, this is what we do to treat it. How do you recommend that our frontline folks work this discussion into every discussion about opioids with patients?
Well, you just said it there. It's a universal offer, right? So anytime you want to reduce the intended or unintended stigma or discrimination against folks is that you're taking an opioid. I want you to be safe. You're showing your connection to the patient. I want you to have this. I want to train your family to have this. And this is something that we do all the time. So if the patient feels like they're being supported and feeling safe, it shows the importance of monitoring for unintended overuse of prescription opioids or use of more potent contaminated opioids that are unregulated. And there are several states that have had success, like the one that I'm in, where we mandate co-prescribing. So with every opioid or every opioid benzodiazepine prescription, naloxone's automatically recommended. It's automatically filled, and you say, here you go. This is what it is.
Mm-hmm.
And so that helps reduce the stigma among the people dispensing, the people prescribing, and the patients who pick up their opioids. This is just something that happens all the time. We want to normalize it.
Yeah, that's great. We also had a question on age limits on these agents.
Yeah.
So how young can we go when giving naloxone?
Anyone with a nose can get naloxone intranasally, or anyone with a muscle. Works on all people. There is no, again, as we go up in dose, we may not see increases, and depending on how it's administered, it varies. But as we increase doses, we may not see greater efficacy, but we know that they're safe, right? Based on the products that have been approved. Even if you're not sure if an opioid is there, the great thing about Narcan is it's really easy to administer. It acts really quickly. You know to call 911. I actually just did a training on CPR, and there's a pathway for respiratory emergencies and the use of naloxone built into that. So anyone who's trained in CPR should also be trained in naloxone. I think everybody should be trained in both. So it's all just part of, like, I'm a first responder. Who are you going to respond to? Most likely, probably one of your family members. And so just have this ready and make sure everybody knows what to do, because you can't respond to an overdose yourself.
Great tips there. We actually have another question. Do you recommend a specific agent for opioid reversal for some of the street drugs like carfentanil?
Yeah, so first, the one that you can get, the one that you're going to carry, right? So there's that. I think the shorter, naloxone has the longest decades-long history of effectively reversing one or two doses, is how it's packaged, effectively reverses it. So there's often media that say, 6 doses were given, and the thing that's hard to parse in those stories are, were 6 doses needed or were 6 doses given? And that just shows how safe it is that people have it and they give it, and that's great. But it's really important to think about, was it actually needed? And very often it's not. We know that an average of 1 to 2 doses is effective, whether it's fentanyl, carfentanil, those types of things. The answer is carry naloxone and use it.
Exactly. Yep. Thank you. So in addition to discussing these reversal agents with patients, what are some other important counseling tips that you don't want to miss when talking with a patient getting an opioid?
So you mentioned one of them is, we focus a lot necessarily on respiratory depression. And I think the key thing is also constipation, right? And so we need to, even as we increase doses, we still should make sure that we're counseling about constipation. And so we have that there, using a laxative, we don't use Docusate, Senna, or other stimulant agents work well. We, again, co-prescribe or co-dispense naloxone, however mechanism they can do that. And it's really anybody who has access to that, you should have naloxone available and known. But the opioids, you can protect them too. You can have proper storage. Nobody except the patient really needs access to those opioids, or if they have assistance to give opioids to someone, know that they can keep those out of reach and keep naloxone within reach. If you have opioids in your house, there's many, many people who have opioids and antibiotics and all kinds of things and creams left over. It's best to just get rid of them.
And then regarding disposal, I know some pharmacies have definitely started handing out the med disposal packets with each opioid or risky prescription. But if we don't have these packets, what are the best ways to safely dispose of opioids?
Yeah, I think, so there's lists online that talk about what's safe to flush. There's the classic mix with kitty litter. Again, I had cats for 12 years. I don't anymore. I do not have kitty litter, but maybe I buy some to dispose of my opioids. But you really can just dispose of them in the trash. You mentioned pharmacies, you have medicine disposal there. I think that's important. So if you can flush it, flush it. If you in your pharmacy where you're getting it filled and you want to get rid of it there are Drug Enforcement Administration or DEA take-back days where there's a location where you can drop off all your meds, including controlled substances. So those are things. And again, it's really just about reducing the risk.
We hope you enjoyed and gained practical insights from listening into this discussion. Now that you've listened, pharmacists, physicians, and nurses can receive CE credit. Just log into your Pharmacist Letter or Prescriber Insights account and look for the title of this podcast in the list of available CE courses. You'll also be able to access and print out additional materials on this topic, like charts and other quick reference tools, from the Pharmacist Letter and Prescriber Insights websites. If you're not yet a Pharmacist Letter or Prescriber Insights subscriber, find out more about our product offerings at trchealthcare.com. Be sure to follow or subscribe, rate, and review this show in your favorite podcast app, or find this show on YouTube by searching for TRC Healthcare or clicking the link in the show notes. You can also reach out to provide feedback or make suggestions by emailing us at contactus@trchealthcare.com. Thanks for listening to Medication Talk.